morning, Jennifer Shepard with the Shepherd Center for Integrative Health on a beautiful sunny day here in Ohio. And I want to talk about the concept of trace and isolate, which is a wonderful, wonderful, wonderful concept from Gregg Johnson with the Institute of Physical Art, and which he teaches through his upper level courses, actually even in our lower level courses. And then we really, really integrate this work throughout the body in fellowship. So I recently had a new patient. She had done rehab for elbow, a radial head fracture, and also dequervins and a carpal tunnel release. And it's interesting, as you go back and look at her story, here's the initial fall where she had a fracture that was just splinted, and then here's residual trauma that had not been addressed or treated with regard to the nerve and joints. So that's neither here or there right now. Unfortunately, I didn't get my hands on her until after she had the surgeries for dequervins and carpal tunnel. But as she comes to me, so she's had a lot of good therapy. She's had some traditional physical therapy. She also has worked with a really good hand therapist who had said, hey, we really think you need some good manual therapy, which again, kind of blows our minds that everybody needs manual therapy. And again, stretching and strengthening is very, very important, but things happen to the body that absolutely affect mobility of structures, and you need a good trained hand to get in there and restore efficient mobility of tissues, nerves, arteries, structure, bones, joints, all of that. Then mobility is increased and strength has a better opportunity to come back. So I digress. But what I wanted to point out is how I use the concept of trace and isolate. So as I looked at, I look at the entirety of her, and absolutely I'm looking at the sternum and how, think about pericardium, whatever accident, there's also some emotional trauma there, how that brings the shoulder forward. Again, the whole alignment of the shoulder girdle, how it affects the elbow and the wrist. So I'm looking at the big picture of her. I'm looking head and neck. Again, as we know, those nerve roots from the neck work their way all the way down to the finger. So again, in our work, we look at whole person, big picture of everything, how they line up against gravity, and then what happens when they go on the table when gravity does not affect their system. But so I went into, as I progressed into, let's look at what's going on at this elbow, range of motion wise, after all of this trauma and surgery and treatment. She had beautiful, beautiful supination, pronation, inflection. It was great. You can tell she had a lot of work there in that position, and again, probably sitting upright, where they did a lot of work on the wrist, on the forearm, maybe into radial head. So, but the problem is, and her biggest concern is when she would go to walk, and how her arm would hurt, would feel heavy as she walked. So I'm thinking, okay, what's end range elbow extension, end range wrist extension? What's going on through the arm entirety from neck down to fingertips as she walks? And sure enough, as I take her into extension, she can get extension, but she really comes into a valgum, and I hope I'm saying that correctly again, an increased carrying angle, if I didn't nail that one. But so she comes out to the side. There's this compensatory strategy to get there. So in our work, as we trace and isolate, and then we compare sides, like, all right, well, I checked her other side. So does she just have a large carrying, a big carrying angle where, the elbow is closer to the side and the arm, I'm sorry, I can't show you, comes out, it just has a bigger angle? No, she doesn't, because the other, it was a decreased angle on her left side. So then we take her through range of motion and back to, all right, well, where do I want her to go? What would be the efficient position, range of motion for her to have clean extension without any tug, any block, any pull? And then what is it that's getting in the way? So as I started to treat her, and again, layers, we're talking about layers, we're talking about structures. What I got into, many, many things. Actually, I started, at the radial head, at the olecranon. And as I took her into extension, I could feel that the olecranon didn't seat well in the little fossa of the distal humerus. So that hadn't been treated mechanically. So I started there, and then came over to radial head. How does radial head, as we fold into flexion, extend, as we rotate, does it have mobility in all directions? And again, trace and isolate, I'm feeling. So I'm taking her through where I want her to go range of motion wise. And then I feel for, hey, what's stopping the motion? Is there something that can't lengthen, or is there something that's blocked? And again, Gregg teaches this in many of his classes, again, what is it? Like, structures need to lengthen, structures need to fold, and if they can't, often that is what will limit our range of motion. But we can feel that, and we can find that with our hands. Is it on the back side? Is it on the front side? Is it bone? Let's get our fingers, right there. And when you get on that spot, your patient's like, oh my gosh, that's that. And often they say, wow, I never realized that hurt. And again, because they never really bang up against it or get into trouble, often their pain is elsewhere, because again, right, here's something that's stuck, and then they compensate elsewhere for it. So usually that's elsewhere. It's what's squawking and talking and getting the attention, whereas the other areas that are stuck, limiting this range of motion, really aren't addressed because they're not talking, but we can feel them with our hands. And so that was where I started, was at the elbow, and I keep retesting. Okay, hey, I got a little farther before she deviates out to the side. So then I keep feeling, okay, where's that next barrier? And as I tell my patients, I rarely treat one structure 100%. I kind of graze. Like, my goal is to improve that range of motion, improve the function of the structures, not just treat one structure and clean it, because very rarely is there ever one structure that's a problem. Joint, soft tissue, nerve tissue, vascular, fascial, all of it we have to look at. And you clean out one piece, and then, okay, what's the next piece that's stuck that I need to clean out? What's the next piece? The big piece I wanted to bring out was, as I worked my way down, was, wow, the shaft of the ulna and the shaft of the radius. So again, thinking about impact came through as she fell multiple times, and then surgery and swelling. And so those bones, the bones of the forearms, were really rigid. And again, bone is living, bone is healthy. When bone is healthy, actually, it should have some give, because it's living tissue. And again, same thing, when it takes impact, forces come into it, forces are absorbed by the tissues, by the periosteum, it becomes rigid. And or I see that too in my high-level athletes, where they use a lot of their outer muscles. Maybe they're actually, very often they're imbalanced. Their deeper tonic stabilizers are not kicking in, and they really do most of the work solely from phasic. So often, like in their running and their gait, they're overusing these lateral quads, and these lateral quads are always pulling on the periosteum of the femur. So then we'll feel that rigidity. So I could really feel the rigidity through the long bones of the forearm, the radius, and the ulna. And then between, so then I got to the tissue. And I'm going to call it the interosseous membrane, because that's what we call it down in the leg. I cannot recall if that's what we call it up in the forearm. But I got in between. And wow, I'm going to take my hands off just for a second. I promise you I'll be safe. But what those bones needed was like this spreading. And she can't do that herself, because she's only got one hand, because she's treating her other hand. But I said maybe her husband can do that. But she really needed space in between. And not even just space, but she needed give, because again, everything was just held stuck and somewhat rigid together. And then treatment went into the carpals and the metacarpals as well. So, but the point I wanted to bring is trace and isolate. And this is where I told her, I said, you've had great therapy. You can feel like, hey, look, in these particular ranges, your range of motion is really quite good. At the same time, here's places where they didn't get to. And perhaps, again, did they not take her into full extension? Probably she needed to be treated in supine for much of that as well. And then did they know to look for, okay, yes, she's got full extension, but comparing it to the other side, hey, that's really not efficient, full extension. And actually the other piece I wanted to bring up was, as she went into full extension, you would see this compensatory, I'm sorry to bring that up sooner, this big compensatory at the elbow. So again, she's working on extension, but then there's this force. It was almost like a teeter-totter for her. So as she extended, that elbow would do this. So you could see that force come on the medial aspect of the elbow as she tried to get into full extension. So she had extension, but it wasn't efficient extension, and she was still having trouble, and tissues were being strained. As we finished up yesterday's session, it was our second session, where we ended up, again, like I said, we worked radial head, working the olecranon. Again, I'm not working that 100% clean. I just get enough off, okay, what's the next structure that I need to restore the entirety of what she needs for walking. So into soft tissue, into where we finished up, where I want to go with that is there was a little protective mechanism that I noticed as I was taking her there, like she didn't quite want to go all the way. So the last piece that we came into that I actually decided to tape her. I decided to tape her a little bit of flexion just to create a little support, because the median nerve, there was still significant restriction of the median nerve, and I didn't have time in that session to, and this is where I will really dive into concentrating the whole time, tracing and isolating. I'm also listening too, because that listening further fines tunes where I need to go very, very precisely. And that's why I tell many of my patients, this work is so precise. It is right there, or it's right here, like where's the angle, where's the depth, where's the direction of the restriction that we need to free up so that we can restore this range of motion. So, but lastly, it was the median nerve, and here she had this this carpal tunnel release. But where I went with that, because I didn't have a lot of time in my session, is excuse me as I make this turn, I did the impact test with her because I was curious. Because as I was tracing and isolating, I wasn't quite certain I could feel where it was just by trace and isolate alone. And again, back to listening, I didn't quite have the time in the session. But I just wanted to rule out, so I did impact test with her, and I had her stabilize prolonged hold at around C5, C6. And there's absolute pathology at her neck. There's inefficient mechanics at her neck, which we've grazed a little bit. And as we stabilized that and got those multifidi back online, that nerve was able to let go, and we were able to get some range of motion. So that was great for her to see, hey, look at how the cervical spine also contributes to this range of motion component as it affects the nerve. So thank you. Appreciate all of your feedback, and please like and share. And I enjoy sharing all of these. Just humans are amazing, and every single patient is different, and we just continue to stay curious and ask that next question of what that patient needs or what that structure needs to help them restore efficient functioning so they can live optimally and live well.